Welcome to the channel where medical topics are made easy. Today we're going to go over the Parkland formula for burns. We're also going to go through an example so you can practice. The Parkland formula is good to know when caring for burn patients, and it commonly shows up on medical and nursing exams. You can find the notes, lecture, and study guide for the video on the website linked down below. All of the videos come with notes and written lectures, so make sure to hit that subscribe button to not miss out on those. Let's look at the formula first, and then we'll go over an example at the end. The Parkland formula is used to calculate the initial fluid requirements in burn patients. The Parkland formula for an adult is 4 mLs times the body weight in kilograms times the total body surface area percentage affected by the burn. This will give you the estimated total amount of fluids the patient should receive in the first 24 hours after injury. Half of that total volume should be given in the first 8 hours, and the other half should be given over the next 16 hours. It's important to remember the first 8 hours begins from the time of the burn injury and not from the time of presentation or when you made the calculation. This means if someone presents to a hospital 2 hours after a burn, they should receive the first half of their fluids within 6 hours instead of 8 hours. So the first half of their fluids may need to be administered at a faster rate due to their delayed presentation. We can see from the formula that there are 3 variables to look at. Remember, this equation is for adults, and we're going to look at the formulas for pediatrics later in the video. First, we have the 4 mLs, which is a constant. The way I like to remember 4 mLs is to use the word 4 in formula. Next, we have the patient's body weight in kilograms, which is also easy to calculate. Finally, we have the total body surface area percentage involved by the burn. This helps determine the extent of the burn injury. Only areas affected by partial thickness and full thickness burns, which are second degree burns and higher, are counted toward the total body surface area calculation. Superficial or first degree burns are not included in the calculation. Determining the total body surface area percentage will require calculating, and there are a few different methods for doing this, so let's take a look at them. One of the more common methods for calculating the total body surface area is the rule of nines. We talked about the rule of nines in the previous video, so make sure to check that out if you want to learn a simple way to calculate total body surface area. Basically, the rule of nines provides a body surface area percentage for different body parts, as you can see in the table and diagram. This can then be used in burn patients as a way to calculate the total body surface area involved. We're going to look at an example at the end, and this will help you see how it works. But if you need a quick refresher on the rule of nines, then make sure to watch the previous video on it. It'll be linked down below in the description. In addition to the rule of nines, there are a couple other methods you can use to calculate the total body surface area involved by a burn. So the first method was the rule of nines, as we just mentioned. The problem with that, as you might remember from the previous video on the rule of nines, is that the rule of nines is most accurate in non-obese adults, and it can be less accurate in children. Pediatric patients have disproportionately larger heads and shorter legs, which can make the rule of nines less accurate, as you can see in the diagram and table. This table and diagram will give you approximate percentages for infants and young children. These numbers will change in older pediatric patients. We can see the head is disproportionately larger at 21% instead of 9%, and the legs are disproportionately smaller at 13.5% each instead of 18% each. This is where the Lund and Browder chart comes into play. The Lund and Browder chart takes into account variations in body shape with age, and this can be used in both adults and children to calculate total body surface area. You can see in the table how it takes into account the size of the head and legs based on age. The diagram shows you the constant percentages of the other body parts. So you can see how the Lund and Browder chart can potentially provide a more accurate representation of the extent of the burn, especially in children. The downside compared to the rule of nines is it's tougher to remember these numbers and less efficient. Another method is the hand or Palmar method. This method states the patient's hand, including their digits, is approximately 0.8 to 1% body surface area, and the patient's palm, not including their digits, is about 0.5% body surface area. Be careful, as you might see some literature simplifying it and stating the palm alone is about 1% body surface area. This has recently been shown to be a potential overestimation, and that the palm is more accurately about 0.5% body surface area. The hand or Palmar method can be used in smaller burns, but remember, you're using the size of the patient's own hand and not your own hand to approximate the total body surface area. Now that the total body surface area has been calculated, we can figure out the total volume of fluids to be given in the first 24 hours after injury. Early fluid resuscitation is important, especially in severe burn patients. In addition to causing local damage to the skin and tissue, severe burns can generate a systemic inflammatory response, which can affect the entire body. During the inflammatory response, the capillaries can become more permeable, which means intravascular fluid can leak into the interstitial space. In other words, fluid within blood vessels can leak out into spaces outside the vasculature where it doesn't belong. The capillary leak can result in large fluid shifts from the intravascular to the interstitial space, which can cause intravascular volume depletion and edema. The intravascular hypovolemia or volume depletion from fluid shifts can lead to decreased tissue perfusion. The body will try to increase vascular resistance by constricting blood vessels in order to maintain tissue perfusion. The increased vascular resistance mixed with worsening hypovolemia can lead to worsening tissue perfusion, known as burn shock. Not to mention cardiac output can also decrease from the hypovolemia. Hypovolemia can decrease venous return to the heart, which can decrease stroke volume, which can decrease cardiac output. So if you remember the different types of shock, we have a combination of distributive shock from the capillary leak, hypovolemic shock from the fluid shifts and intravascular fluid depletion, and cardiogenic shock from the decreased cardiac output. The way to treat this is with aggressive fluid resuscitation with the goal to maintain tissue perfusion and prevent end organ damage. Therefore, fluids play an important role in the management of circulation in severe burn patients, and this helps decrease morbidity and mortality. So hopefully you can see now why fluids are so important and why there are formulas and protocols to calculate fluid requirements, such as the Parkland formula. The Parkland formula is one of the most well-known and widely used formulas to calculate initial fluid requirements in severe burn patients. Again, the Parkland formula for an adult is 4 mLs times the body weight in kilograms times the total body surface area percentage affected by the burn. This will give you the recommended amount of crystalloid fluids to be given over the first 24 hours after injury. The first half of the volume is given in the first 8 hours after the burn, and the second half is given over the next 16 hours. The formula is used for partial thickness and full thickness burns that are typically involving more than 20% total body surface area in adults and greater than 10% total body surface area in children or the elderly. Burns involving a total body surface area less than that typically don't cause massive fluid shifts, and the patient can usually tolerate fluids by mouth. But that's not to say the patient still won't need IV fluids, and the Parkland formula still may need to be used. The Parkland formula can also be used in those with smaller burns but have injuries to the mouth or inhalation injuries that would prevent them from tolerating fluids by mouth. Those with heart failure, kidney disease, or other comorbidities that may affect fluid resuscitation should have their volume status closely monitored. While the Parkland formula is the most widely used, there are other formulas out there that can help you calculate the recommended fluid volumes as well. We're not going to go into detail on these because the Parkland formula is the most well-known, and it's commonly what shows up on medical and board exams. But this is just to make you aware that other formulas exist, and depending on where you're from, different parts of the world may have different institutional protocols. Now that we know how to calculate fluids for adults, let's look at the formula for children. The formula is the same with the exception of 3 mLs instead of 4 mLs. So the formula is 3 mLs times the body weight in kilograms times the total body surface area percentage. Children should also receive maintenance fluids in addition to their calculated fluid requirements. The simple way to calculate maintenance fluids in pediatric patients is using the 4-2-1 rule. The rule states to give 4 mLs per kilogram per hour of fluids for the first 10 kilograms of weight, 2 mLs per kilogram per hour for the next 10 kilograms of weight, and 1 ml per kilogram per hour for each kilogram of weight after that. Other formulas for children besides the Parkland formula include the Schreiner-Cincinnati and the Galveston formulas. Again, these formulas are not the main focus of this video, but make sure to know what your institution uses or recommends. Let's look at an example so we can see how the Parkland formula works. The patient weighs 80 kilograms and has partial thickness burns involving the entire anterior trunk and the entire anterior right arm. Hit pause on the video and figure out the recommended fluids this patient should receive in the first 24 hours using the Parkland formula. Also figure out how much fluid should be given in the first 8 hours and over the next 16 hours. First, we have to calculate the total body surface area, and we're going to use the rule of nines to do that. We know the anterior trunk has a total body surface area of 18%. Next, we have the burn involving the entire anterior right arm. We know the entire right arm has a body surface area of 9%. Since the burn only involves the anterior aspect, then it's 4.5%. So this patient with partial thickness burns to the anterior trunk and anterior right arm has a total body surface area of 22.5%. Since this burn involves more than 20% total body surface area of partial thickness burns, we can use the Parkland formula. We know the patient weighs 80 kilograms and has a total body surface area percentage of 22.5, so we will multiply 4 mLs by 80 by 22.5. This will give us 7,200 mLs of fluid recommended within the first 24 hours. Remember, half of that, or 3,600, will be given over the first 8 hours, and the other half, or 3,600, will be given over the next 16 hours. Just a few points to wrap up the Parkland formula. First, it's important to remember these formulas are guidelines and they're not hard and fast rules. The Parkland formula may underestimate fluid requirements in some cases, especially inhalation injuries, electrical burns, full thickness burns, and those who have delayed resuscitation. The Parkland formula may also overestimate fluid requirements in other cases. Underfluid resuscitation can lead to hypotension, poor tissue perfusion, acute kidney injury, end organ damage, among others. Over-resuscitation can lead to compartment syndromes, acute respiratory distress syndrome or ARDS, among others. Therefore, you'll need to use your clinical judgment and monitor the patient's fluid status on a case-by-case basis. For example, you can monitor hourly urine output through a Foley catheter, as well as the patient's vital signs, respiratory status, and mental status, to name a few ways. After 24 hours of fluid resuscitation, the Parkland formula, as well as other formulas, will provide you with recommendations for the next 24 hours. Hopefully this gave you a better understanding of burn management and fluid resuscitation. If you found the video useful, please hit that like button and leave a comment. Make sure to subscribe to not only catch future videos, but also all the videos come with notes and study guides that you don't want to miss out on. The notes and study guide for this video are linked down below. Thanks for watching, and hope you check out future videos.